If there's one sibling in the family that's diagnosed with autism, we know that 1 in 3 other children would stand a chance to have autism as well. So there is a very strong genetic potential. I'm Sebastian Gericke. I'm a pediatrician that works in private practice here in 𝗘𝗶𝗺𝗶𝗀𝗃. I've been here for just over 4 years now. My special interest is neurodevelopmental pediatrics, so this is what really interests me. Almarie, I just want to take my hat off to you and your organization. I think as far as pioneering autism awareness goes in 𝗘𝗶𝗺𝗀 and definitely in Namibia, you guys have really been at the forefront. I think we're still very much in our infancy in terms of caring for children with special developmental needs. And as we know, statistically, just off the cuff, we know almost about 10% of children do not fit the typical mold in terms of being able to sit through a didactic teaching sitting in a school. So it's actually a vast problem, of which autism is one of the specifically described conditions. So thank you for that, and thank you for this evening and creating awareness for autism. I think it's definitely needed. And I think our expectation as professionals, which I'm very proud to say, I think we've organized ourselves as professionals in this town in a very exciting manner. We've got a lot of collaboration, and we're very excited about helping children with these needs. And there's obviously lots of challenges, which we might touch on some of them tonight, but otherwise I'll basically just be giving you some information about autism. Just off the cuff, a quick disclaimer. So my talk tonight is intended mainly for a non-professional audience. So it's not going to be exactly per definition as it is, but I'm going to try and make it a bit more palatable, perhaps for parents and for those who are interested. So first of all, what is autism? So autism basically describes a very characteristic pattern of behavior, which we can broadly divide into 2 subsections. So the social aspect, which is very closely related to language and communication. So there's a very clear, limited language component, which we'll be describing in a bit more detail. But the social behavior aspect that's unusual also includes difficulties adjusting to change, sensory hyperstimulation, preference to play alone. So there's a different peculiarity that we see in terms of social interaction. And the other big overcoupling characteristic is these repetitive actions that we see with these children. So there's a resistance to change. They prefer repetitive activities. They want things to remain the same. There's oftentimes an intense interest or obsession with certain objects that they like to keep close or like to interact with. And oftentimes they interact with them in an unusual manner as well. And then we also see the repetitive self-stimulation activities, and that we can see the insistence on routines that they like as well. So there's very much a repetitiveness in the way that they interact with the environment. Autism itself doesn't imply a specific medical illness. So the diagnosis is purely a behavioral cluster of symptoms. And that's oftentimes brings about a bit of a challenge as well. So autism is a group of conditions. So under the autism umbrella, we have a whole spectrum of conditions. So in the past, we used to subclassify these into Asperger's, into high functioning and low functioning and so on. So now we really made the group quite broad because we see the behavioral characteristics overlapping are the same, even though amongst the group there are peculiar differences. So ultimately the goal is to describe not just the child who has autism, but to describe each child's specific features and their own weaknesses and their own difficulties so that we can try and address those weaknesses specifically. If I can use an analogy, it's almost like we diagnose you belong to a certain family. So your family has very specific characteristics. We know you talk similarly, you dress similarly, you go to similar places, you interact in the same way. But in that family, there's lots of differences that we can see with that. I think one of the big overarching differences is that we see that we have autism with high intellectual functioning and those who have lower intellectual functioning. And those with higher intellectual functioning are often those who stay in a mainstream school, and they oftentimes get diagnosed quite late because they might be high performance students. So we've had a couple of girls, especially in the last couple of years, that presented with eating disorders and anxiety and depression And when one delves closer and see from a young age a developmental period, you can see that there's not just the anxiety, but there's a peculiarity in social interaction and these repetitive traits that come to the foreground as well. And oftentimes you need a very intentional diagnostic interview to unmask these things. But I think our focus for tonight mainly, and I think the community focus is for the children that are marginalized, the one with that struggle with their functions in terms of a mainstream school or struggle to adhere to the structures that are already in place for children. So the big question is, what causes autism? And there's no simple answer for this. Because autism is such a cluster of a very broad group of conditions, there's probably not one single cause. But we know there's a very strong genetic tendency. So if there's one sibling in the family that's diagnosed with autism, we know that 1 in 3 other children with standard chance to have autism as well. So there is a very strong genetic potential. We also see that some syndromes like Fragile X and Down syndrome and Angelman syndrome, so those are genetic conditions, have a strong association with autism as well. So there definitely must be a genetic correlation that affects how the brain develops in the early developmental period. Unfortunately, there's no specific blood test for autism. So if it was this easy, we would have found that other 477 children in Swakopmund by now already. We also know it can't be purely genetic, because if we look at identical twins, where the one twin might have autism, the other one might not have autism. And this has been quite well described. So there must be some sort of environmental trigger. This is where a lot of speculation obviously lies in terms of vaccinations, medication, food processing, etc. And we'll perhaps be touching on a bit of those as well. What we know when we look at postmortems, which is a routine thing, it wasn't just targeted on autistic people. So postmortems oftentimes get done for unnatural deaths and so on. And if someone who had a diagnosis of autism has a postmortem, we see that there's very peculiar differences in how the neurons, the specific brain cells in the brain develop. A brain cell is almost like a little tree. It makes a lot of branches and connects to other brain cells in the brain. And we know that this process of connecting to other brain cells is different in children with an neuroatypical brain. Autism definitely seems to be on the rise, and I think there's a little bit of controversy here. There's definitely an increase in incidence, but I wonder if there's also not a bit of a overdiagnosis in terms of making the categorization a bit too broad. So we know roughly 1 in 70 children. The odds vary depending on the geographic area that you're looking at. It's definitely increasing a lot, especially in America, where they say 1 in 44, as almarie has quoted as well. In South Africa, which is the closest representative of our data, they have about just under 1%, which is 1 in 100, almost similar to the UK data that we see, and we don't know in Namibia. But what we can surely say, and what Ansi, our speech therapist, and Aurea, occupational therapist, that they would resonate, is that we see a lot of children with developmental problems, specifically speech delay, attention deficit hyperactivity, children who present with autism. Our practices are really flooded with these children. And it might be that these children were previously undiagnosed and now we have a platform for them to access diagnosis and treatment, but it definitely does seem that it's much more than in the past. I think it's important to emphasize what autism is not. So autism is certainly not related to vaccination or the preservatives or any other parts of vaccination. I think when that oftentimes comes in, especially with the MMR vaccine, is for 2 reasons. There was a pediatrician in the UK that shamed the profession by falsifying research, specifically with the MMR vaccine. And the other one is a bit of a difficulty in science. When 2 things happen at the same time, it's very easy to say that there's a correlation or the one thing causes the other. A simple analogy might be if the rooster crows in the morning, the sun comes up. So it's not because the rooster crows that the sun comes up, the 2 happen at the same time, but it would be easy to say that the one causes the other one. So the same with the MMR vaccine. The MMR vaccine gets given at about 18 months, the measles, mumps, rubella vaccination. And 18 months is sort of the time where you expect a child to have language fluency, and we can see if there's a clear differentiation from that developmental trajectory. So it's easy to give vaccinations the guilt for causing some of these things because there's vaccinations scattered throughout the child's developmental process in any case. Then there are so many other environmental things, and I think for us as people who work with children, our main concern is digital media. So I think that is a major talk about the excessive exposure of digital media and the well-described impact that that has on language and attention. You can just imagine for yourself. If a child gets brought up in front of a screen and that becomes his measure for what engages his attention, then everything else is going to fall short by comparison. If a screen is your measure of what should be entertaining, then eating a plate of food that doesn't jump around, it doesn't flash, it doesn't do anything, it's extremely boring. Hey? So to sit and eat a plate of food, or to listen to a teacher, or to do anything else like reading by comparison is extremely boring. So even if you do not have autism or have the peculiarities of an autistic brain, we know that early and excessive digital media exposure has a massive influence on children's development. We also see there's a lot of other things that we probably need to consider. The way that we treat pregnancies, the way that we engage in our society, there's a lot of things that change. So some interesting things is that we see that there's quite a difference between males and females. About 1 in 48 boys are diagnosed with autism and much less females. And that's probably because girls tend to mask. That's a gross generalization. But we do see it in practice a lot, that girls tend to learn social behavior. We see that the social peculiarities is one of the core aspects of autism. And girls tend to sort of parrot learn because they tend to be more tuned into social cues. So they tend to be able to mask these things for much longer. But the problem with that is it is extremely exhausting. Going home and ruminating the whole time about how did I stand? How did I engage? How was my tone of voice? What did that person mean with what they said? Should I have said that? Should I have interacted like that? And eventually, the mounting or the cumulative effect is anxiety and depression. How do we identify autism, or how will we first pick it up? And I think the main thing is that children develop at a very predictable pattern. Everyone sort of knows that children roughly crawl by about 9 months. They tend to walk at about a year. They tend to run at about 1.5 years. Children tend to be able to say mama and papa at about a year. They start to join words at about 2 years. So it's very predictable. And if you deviate from this very predictable pattern to a marked extent, then we can say that you are on a different developmental trajectory, and we should pay close attention to that. And language being probably one of the biggest things. With autism, there is a lack of intent to communicate. So it's not always just the child, specifically a boy, that might be a slow learner in terms of language. That's one aspect. But with autistic children, we see that oftentimes there's a lack of intent to communicate. Or if they communicate, it's unusual. And one of the strange, peculiar things is they might seem to learn a word for a day, and the next day they don't have the ability to use that word anymore. So it doesn't seem to stick. There's other strange uses of language that we call echolalia, so repetitive rephrasing of words that they've heard that they just ruminate over and over again, and oftentimes without any intent to communicate something. They might have unusual tone of voice. They can oftentimes mix their pronoun, aunt instead of uncle, him instead of her, and they can oftentimes refer to themselves in the third person. So a very peculiar way of communicating. The other reason why children oftentimes present to my practice is for behavioral difficulties that parents have. Meltdowns. So oftentimes autistic children might experience the world as a very strange and unusual place, especially because they tend to like things similarly. Hey? So we said there's a bit of a resistance to change. So if things are loud, or if it changes, the routine is not repetitive as it always has been, things suddenly become very scary, and this oftentimes leads to meltdowns. They might sometimes not present to be comforted when they are hurt, or if they do get hurt, they come with a bizarre way of being comforted. So they want you to pat it or put plasters, 10 plasters on it. Everyone likes plasters, and you know that, but it's unusual in the way that they present with their concerns. Eye contact, we know, is one of the strange things, and one of the early things that we sometimes see is when mothers breastfeed or feed, there tends to be a eye contact and a bonding moment there. With children with autism, that's oftentimes omitted, where there's not that eye contact and joint attention sharing that we would see. Oftentimes, children with autism tend to prefer parallel play. So, okay, you can play there, I'm playing here, but don't come interfere with the way that I've lined up my toys, or don't come change the way that I've arranged my environment because I insist that it stays in roughly the same way. And then there's the sensory aspects. Children tend to present with unusual sensory things. They rock, or they bang their heads, or they tend to be humming to themselves or flapping, so in a way that they tend to self-stimulate. The language delay is something that's very important. And as I said, this is one of the main peculiarities of autism. So I think it's worthwhile just to speak a little bit more about this aspect. Oftentimes, parents present with a child, or they were referred or told to come to a pediatrician or to a therapist, which is sometimes one of the worst scenarios, is that we can see that children present with the parents, but the parents are unwilling to engage. And then oftentimes there's a notion of saying, my child's speaking late, I also spoke late, it's going to be fine. Or especially in certain cultures, there must be something tied under the tongue. It needs to be cut. So we see that very often, that there's such a simplistic definition for a child's language delay that it must just be cut. It must just be loosened. The tongue must just be loosened and everything is fine. But we can know it cannot be this simple, because it's not just the expressive language, it's the way that there's an intent to speak. It's also the understanding of language, and it's the engagement of social interaction, not just restricted to language, but also body language and the way that you're able to describe things. So there's a definite peculiarity with not just expressive language as well. Some of the other things that oftentimes gets downplayed, say it's a boy, we have a bilingual household, there's older siblings around the house, the child understands language fine, so it must be fine. Or he speaks fine at home, but it's just at the school where he doesn't want to speak. We know that children by the age of 18 months should reach a relative fluency in the way that they speak. And we consider things not abnormal if it's slightly deviated. We would consider things abnormal if 90% of children in a population would have attained a certain developmental skill, and if a specific child has not attained that skill, irrespective of whether we are going to give it a name later on, it warrants special intervention. Oftentimes I have to use an analogy with my patients saying, if a muscle is weak, you don't leave it for it to get better by itself. You have to exercise that muscle. And the same is with language. If we see that there's a language delay, which oftentimes deters parents from presenting to therapy because they're scared that we're going to sentence them to some sort of condition that's going to change their lives forever. But what we should do is early intervention. So I think the big awareness that we need to make is every child with language delay should have early intervention, irrespective of whether they will catch up. Because we know that many children might catch up, even though there might still be residual difficulties in the future. It's not possible to easily predict which children will catch up and those who will oftentimes go on to have more pervasive difficulties. So there's lots of benefits of early intervention. We know that children who present very early tend to have reduced severity scores of autism. There's significant long-term improvements in language acquisition. There's improvements in social skills. There's improvements in cognitive abilities, and there's improvement in adaptive functions, how you're able to function on a daily basis in your life. So quickly, just something about Asperger's. We don't differentiate this that much anymore. It falls under the umbrella of autism spectrum disorders, but Asperger's is quite an interesting condition in the sense that these children oftentimes have preserved language. So they tend to be able to speak quite well, but there's a very specific difficulty in other areas as well that you cannot ignore. They oftentimes might have an exaggerated fascination with things like dinosaurs or trains or collecting historical facts. And these things are oftentimes impairing in the way or in the intensity that they are pursued. Asperger's is typically seen as high-functioning autism. They tend to be verbal, but they're still very stereotypical or bizarre interests. And this doesn't include necessarily the typical savants that you might see as well. So other conditions with any child that presents with language delays, we have to be proactive. We always do hearing tests to see if there's any hearing difficulties because we want to identify things that can be managed or treated. And we oftentimes might test vision. Any child with sensory difficulties might present with unusual behaviors as well, frustrations. And then we also want to look for certain syndromes. We don't typically test for genetic things always, but some children present with syndromic autism, where we might look at genetic conditions. Autism itself is seldomly a condition in isolation. We oftentimes see other things: attention deficit disorder, obsessive compulsiveness, anxiety, and we can see sensory stimulation problems. So it's important to look at the broader things because we want to identify every specific area that we can give intervention. As a parent, what would you do when you finally receive the diagnosis that your child is autistic? Oftentimes comes as a great shock to parents. Oftentimes there's a lot of stigma, like other medical diagnoses might have. And I think the best thing to do when you have a child that's on a different developmental trajectory is to surround yourself with professionals who have knowledge of this complex condition. That's the best thing that you can do, because in isolation, it's a very difficult mountain to climb. And this is especially difficult in rural conditions and in our patient populations that do not have access to medical aids, which is very, very lacking, obviously, in Namibia. So obviously you might surround yourself with a pediatrician, occupational therapist, speech therapist, play therapist, family-centered therapy, psychiatrist. All of those professionals can form part of a comprehensive approach, and parents oftentimes get overwhelmed when we say, listen, we've come to this point where we can diagnose. Now, these are some things that we need to do, and oftentimes we need to stagger it. Because if you come and I say your child doesn't eat, so let's consider sending you to a dietitian so we can help make your diet a bit more calorie dense. You should start seeing 𝗬𝗙, our speech therapist. And there's so many other therapists that can offer assistance, and parents oftentimes get overwhelmed. But there's so many things that we can offer, even in 𝗘𝗏𝗺, where we've really made a lot of headway with these things. I think something that's very important is oftentimes it might seem like your child's plateauing in terms of development. So it's worthwhile taking a video clip every 3 months and reflecting back on that and seeing how the progress has been, because there's oftentimes are strides in development, but they seem to be so stretched far apart that it's difficult to see them on a day-to-day basis. The main thing is to keep children stimulated and meet their needs. And there's some of the things that we can do with medication as well. So medication can address attention deficit and hyperactivity. We can address anxiety. And we can even address some of the more bizarre things like the self-stimulation and the obsessive compulsiveness and the meltdowns. And that's pretty much where our medical intervention ends. Last slide, I quickly want to mention just about things that cannot be done or that should not be done. I think very important, where there's a desperate parent, there's someone that's ready to take your money and to offer you something that's going to be of benefit to your child and going to make false claims. And as a responsible parent, you're going to not keep any stone unturned if it can offer your child some benefit. Unfortunately, there's a lot of things making claims of improvement, and there's unfortunately just no magic bullet with these things. So oftentimes things like carnitine or omega-3 or a lot of complementary things are offered, and these things are oftentimes not even tested in children. Not so long ago, I met with a rep who offered treatment on one of the school platforms, on the website of one of the big schools in 𝗘𝗏𝗺. And when I met with them and I asked them, have it even been tested in children? They said no. And I asked them, are you monitoring to see if there's any side effects of these things in children? They said no. Said, like, how do you know if it even can make a claim because of therapeutic effect? Because they said because it helped for adults with depression. So I mean, it's such a bizarre thing how you can just sell these things to children and trying to get parents' hopes up. So it's a completely unethical industry. Some people, even doctors and other therapists, might offer metabolic testing, very expensive testing, oxygen hyperbaric treatments, stem cell transplants, and unfortunately, there's none of those things has really been shown to work, including also brain scans. We know that those things don't really offer any special therapeutic intervention. And that is pretty much what I want to say. That's been quite a mouthful. So I'm going to introduce Aurie is our resident occupational therapist in 𝗘𝗏𝗺, and she's at the Dome Occupational Therapy Center.